Hello everyone and welcome to CT Anatomy. My name is Clark and I will be taking you through a bit of neuro today. And so first things first, we're going to be discussing the H test, and then I'm going to be giving you a little bit of understanding of what on earth Dr. M was talking about when he was discussing the critical or pruning period of the visual system in development. And then we're going to address a little bit about seizures, and then we'll be discussing some of the sensory and pain pathways and deficits that you find there. So first, without further ado, the H test. And so what is the H test that we can try to understand here? And so the H test is used to determine if a patient has deficits. So usually the patient's going to come in, oh, I have double vision and it's making me kind of sick. Can you help me figure out what's going on? And so you're going to need to do the H test and determine if it's maybe a major cranial nerve deficit, which is what this test is for, or you can further progress to your neuro testing, which is going to be your red glass test, which I know you haven't learned at this point, but when that comes up, definitely recognize that that is very high yield for your exams when it comes. So as far as major cranial nerve deficits, we're going to be assessing it through the H test. And so I have this kind of picture just kind of describing each the right and the left eye of this patient that I'm looking at as I'm assessing them with the H test. So remember, we start right in the middle here. We'll hold something about 1.5 feet away, and maybe just a light or a pen or something like that, and have them stare at it. Make sure you don't turn your head, but just your eyes, and follow the pen. And you make the shape of an H. And so you're going to go off to the left, up, down, and then to the middle, and then right, up, down, and then to here and back to the middle, and then you're going to go inward for accommodation, just to make sure that they can see that correctly. And so what are we testing with all these things? And so we need to analyze and isolate each of the eyes separately before we can understand what on earth is happening. And so actually I'm going to type one more right in here. And so that's going to be your medial rectus for right here. And so we have different muscles and different cranial nerves that are going on in these actions. And so let's go ahead and analyze it. So we have primary gaze, which is in the middle. They're staring straight at us. And then we're going to go off to the patient's right, or our left. And this is going to be assessing for the right eye cranial nerve 6, which cranial nerve 6, our LR6, does our lateral rectus, LR6. Right? And for the left eye, it actually has the eye go medially towards the nose, and this is controlled by your medial rectus and cranial nerve number 3. Now that this eye on the right side is in this laterally rected position, it isolates and only allows via physics, and just keep my word for that, that we can utilize the superior and inferior rectus, which is controlled by cranial nerve 3. So you go up and down and then back to here. So that's going to be your right eye. So cranial nerve 3 for up and down once we're out here, cranial nerve 6 to get out here. Now for the left eye, since we're medial brought in towards the nose, for up and down is going to be a little weird. So I need you to remember this, that for when your eye is inward, that it's opposite as far as the muscles we're testing. So for here, we're talking about the obliques. So the oblique muscles are going to be what we're testing up and down when we're going inward. Okay, so when our eye is inward, we're testing up and down for the obliques. But remember that for up is actually inferior oblique, and down is superior oblique. And what are the nerves that control that? So medial rectus was cranial nerve 3. Inferior oblique is also cranial nerve 3, and that has your eye go inward and upward when you're testing this. And then for downward, when it's inward and downward, that's going to be cranial nerve number 4, which SO4, sulfate, controls your superior oblique. And so that's kind of the basics, and you're going to repeat it on the other side, testing for these other guys on the opposite side, and just to see if this patient has any deficits. Now for your OSCE, the patient's eyes will be fine, but as far as your written exam, you're going to need to understand deficits. So let's go ahead and talk quickly about what each of those entail. And so we're just going to deal with deficits on the right eye and kind of describe where the eye position is for that, and then it's going to be pretty much mirrored for the left eye. So let's just look at the right eye here. So we have our patient's right eye, okay, and we're staring at primary gaze in the middle, and when we have the patient's eye move rightward, or try to, and this patient can't, we see that the patient, or the eye still stares straight at me and is not able to look at my little pen or light. That means that I have a deficit in this guy right here. Simply, the movement from primary gaze to the side is only controlled by lateral rectus. Simply put, cranial nerve number 6 damage. When you get into a little bit neuro and brainstem, you need to know where cranial nerve 6 is in the brainstem, as that might be an answer as well, along with a bunch of other associated symptoms. It's actually kind of a pretty fun game. And so we have our lateral rectus here that controls lateral gaze. So if this patient has damage here, simply their eye is going to be inward. They also might be able to stare straight, but they aren't able to laterally rect or move their eye out to the side. And that's just simply these. Now let's say this patient can do this. They can pull their eye out here. And now we have them look upward. Okay, and this patient can't do that. Then we're testing this particular muscle. If they can do all the other things with their right eye, every single other muscle, then we're only talking about deficit in superior rectus only. It wouldn't be cranial nerve number 3, right? And if we did the same thing and they could do upward, but they couldn't do downward, but every other movement of the eye is fine, they just can't go out and then down, then that's going to be inferior rectus. Now, let's talk about cranial nerve number 3. That's a major deficit. So when you have cranial nerve number 3, that means you lose the ability to move medially. You lose the ability to look upward and downward via control. Then your patient's eye is actually in a fixed position outward and downward. And you're going, what? I thought we couldn't go downward. Simply put is this. The muscle that controls downward movement when your eye is out, like controlled, when you can use the nerve to contract that muscle, is this right here. Cranial nerve number 3 for inferior rectus, but we damage cranial nerve number 3. However, we also have another muscle that controls specifically this direction, outward and downward. It's specifically focused here. It's not just outward, but it's outward and downward. And that is actually your superior oblique. I know this is really weird, but your superior oblique is right on top of your eye, and it pulls this direction inward. When it pulls this way, then your eye kind of twists around, and because it pulls on the top side, it actually pulls your eye downward. So it kind of pulls on the top and it twists and downward. And that is via your trochlear nerve. So if your cranial nerve number 4 is intact and your cranial nerve number 6 is intact, which pulls your eye outward, but your cranial nerve 3, which does all the other things, there's only one compromise between outward and outward downward. And that's outward downward. So that's where your patient's eye is going to be. And that's going to be a cranial nerve number 3 deficit. Now let's talk about cranial nerve 4 deficit. This is trochlear nerve deficit. And this is just really weird because your trochlear nerve, cranial nerve number 4 for your superior oblique, pulls your eye outward and downward. If you can't do outward and downward, that means your eye gets pulled inward and upward. And simply put, that's what trochlear nerve or cranial nerve number 4, superior oblique muscle palsy will lead to this person's eye is inward and upward. Because cranial nerve number 3 is just fine, it can pull it inward and it would go upward as well. So that's what cranial nerve number 4 deficit. And that's the H test and the deficits for those. That's what you're going to find in anatomy. If you have further questions, definitely post them on our Facebook. So let's go ahead and talk a little bit about pruning. So I'm going to draw actually a picture for this because this is kind of annoying how the doctor kind of put it and it wasn't super helpful. So let's go ahead and talk about this.
Okay, hey guys, so we're over here on the whiteboard, and we're going to be discussing a couple of the concepts that you've gone over in lecture but might have been a little confusing. And it's kind of important to get the basic concept down. It's more clinically relevant than it is for any particular details, but just the concepts to get across. And so you've learned about the critical periods of development as far as the visual system and how that works. And so I have an analogy that goes along with this that really helps grasp what was taught in lecture in a way that you can understand, as opposed to just kind of showing you a picture and going, oh, that's definitely what this means, don't you understand, and then continuing. And so you talked about how there's this critical pruning period, this time where your brain after birth undergoes some pruning. And so how this works is we have our visual system. So let me draw two eyes. Okay, and we have this person looking forward. And we have our visual system that comes in here. And I'm just going to simply draw lines straight back here just to make it very simple. I know it crosses over and does a whole bunch of stuff, but I just want to show that we have the patient's left and we have the patient's right here. And they're going to be looking forward, and there's retinal cells that align on the back side of the eye that take in light information, light that comes in from out here, right? And after birth, right after birth, babies can't see very well. And what is the explanation? The explanation is back here in the occipital cortex. And in the occipital cortex, we have an overlaying of all the fibers that are taking in input from the left and right, and they're all kind of intermixed and all aligned, and they're all wanting to communicate and everything. And so all these cells are active, they're all metabolically active, they're all utilizing glucose, and it's just a crazy mess. So none of this is organized, and the little babies can't differentiate what they're seeing out in their world here because they don't understand it once it gets back in the brain. And so this is how you're born. You're born with a lot of fibers and a lot of connections, and what you need to do is you have to organize it. You have to prune it. So when this baby's eyes are focused on one particular object, maybe just the nose of somebody, or just a car light, or just the smile of the mother, or something like that, very particular, whatever, maybe it's just a little hair that they're looking at. Whatever it is, it needs to organize it that when we have a little fiber here, one little dot fiber, then when this communicates back here, it only wants to talk to one fiber back in the occipital cortex. Why is this important? Because we also want to have from the other eye that's looking at that same little thing to trigger one cell to come back, and we want them to meet in the same place. And so once we have this, we have +1 sensory from your left eye and +1 sensory, and if they hit the same place at the same time, then we get a +2, and we understand that we see whatever it is we're looking at. However, if our eyes are connected to a bunch of different fibers, maybe they're all hooked in here, we get all confused because one eye is picking up information more than the other, and so we're not really focusing on any one particular object. And so this critical pruning period is set up in a way of columns. And so you guys learn about these different columns that align up and how it's organized. And I'll start my analogy in just a second. Is we want to organize these columns in a way that we have input from the left eye and the right eye, and that all they have to do is communicate and say, did we see the same thing? And when they do, that's what our perception is. And so how do we do this? How do we do this? So here's my analogy. I'm going to move this whiteboard over just a little bit. So pretend we have, and we're going to utilize hands instead of eyes because it's a lot easier. So we have this person. I'm a very bad artist, so forgive me. But we have this person's left hand. And then we have this person's right hand. And so this is all the information that's coming in, and we're going to utilize this. This is representative of the hands. Okay, that's a terrible right hand. But this is how we're going to use our analogy from our hands to our eyes. But we're really focusing on the eyes, but I'm just using the hands as an analogy. And so we have left hand plus right hand. And when we overlay these, in a baby, what this looks like, let me go ahead and erase this. What this looks like is a whole mess. Looks like a whole bunch of fingers, and it's just all unorganized. So this is what, when we put one hand on top of the other, it's just all over the place. And so there's no organization. So I don't know if I'm seeing the same thing from both eyes. So I actually can't perceive any details about what I'm looking at. And so what we need to do is organize it. So when we have one hand and the other hand overlaying one another, I'm going to draw that's a very bad picture as well. When we have these hands overlay one another after pruning, then what we see is pretty much one organized hand. That means input from the left and the right are seeing the exact same thing. It's like you're telling your friend something and they don't believe you, and then someone else tells them that same thing and I go, oh, okay, and now I believe you. It's kind of double confirmation. When you get that double confirmation of what you're seeing, then you have this organization, and that is what you perceive. That is a car. That is my mother's smile. That is a marble or something like that. And so this is actually what happens in pruning, is we kill off the cells we don't utilize, and we keep the cells we do utilize. And so I know it's a little bit convoluted right now, but don't worry, we'll get to it. And so I'm going to label this as A and B. So left and right are A and B. And so let's go back to this column aspects. We have A, B, A, B, A, B. And so input from the left and input from the right, and then left, right is how these columns within your cortex of your occipital lobe are organized after pruning. So how this works is, before, when we didn't have pruning, we had A on top of B and B on top of A, and it was very unorganized. So we needed to kill off these extra fibers so that it goes A, B, A, B, A, B, A, B. Therefore, all we have to do is have one connection that says, from my left eye, I saw a marble. From my right eye, I saw a marble. What did I perceive? A marble. Where from the left eye, without pruning, I saw some round thing. On the right side, I saw a glowing light. They're different. They come back. Are they perceived as the same thing? They're not. So that's what happens without proper perception and pruning after this. So let's utilize that aspect of example he gave you. So he showed you this image of this occipital cortex that was cut out with these zebra lines in it. And he said, oh, this is pruning. You should understand this. And then he kept going, and you're probably all going, what on earth is he talking about? So this is an experiment. I'll explain the experiment. So we had these monkeys, and they were staring at this particular picture, and the picture looks just like this. And this is what the picture looks like. It's just this white line, black line, white line, black line, white line, black line, right? And so we had the monkeys staring at this, and we injected them with some radioactive glucose. When we injected them with radioactive glucose and had them stare at this for 15 minutes, we're going to be stimulating different cells. So some cells are going to light up. So these ones that are the retinal cells that we're looking at, this white line, is going to light up, stimulated. And the black lines are inhibited. Why? Because in order to stimulate a cell, you need light. And if does black emit any light to hit your retina? No, it doesn't. It actually is pretty much the same thing as dark. And so it's inhibiting your cells. So therefore, these cells A and B are here. So A is going to go back and say stimulate. And it's going to go back to the retina, or it's going to hit the retina and then go back to occipital cortex and say stimulate. And so this is why we see white here. And then we have this inhibited, so it comes back here, it doesn't do anything, and it remains dark. All these cells that these ones are communicating with. And that's why you see this alternate pattern. And so it kind of maps out on the occipital cortex. It's organized exactly how the retina is viewing the information. What the person sees, or the monkey sees, out in its environment, comes back and stimulates the cells in the back of its brain in the same pattern. So we can see this pattern. And only will you see this when there's pruning. Why? Because in order for the left eye and the right eye to be overlapped, that means that when the left eye and right eye are both looking at this white column, that means they're going to come back and stimulate these same cells in the white area, and it will become white. Where this dark area will come back here, and it will be inhibiting from your left and your right eye will come back to the same cell and say, we didn't see anything. When we didn't see anything, it leaves a dark line. And so that's just the basics of this experiment. You don't really need to know any more other than it's very important when you have babies that have cataracts. You have a limited amount of time to fix those cataracts because it has to go through an initial aspect of pruning, and it's only within the first 2 years of life that this pruning occurs. If you don't fix those cataracts and they don't have this time to cut away cells they don't use and keep the ones they do, it's going to be all a mixed, and that patient will be blind for the rest of their lives. So that's really the most important thing, is to understand that you start with a whole mess and you cleave away ones you don't use and you save the ones you do use and you organize them in columns so that when you see something in particular from the left and the right, they match up and are perceived as one particular item that you're looking at. And that has to happen within the first 2 years, so fix cataracts in babies. Okay, so the next concept, actually just a few definitions. So you guys talked about seizures, and people were wondering, do I need to know EEGs? You don't need to know how to analyze and interpret any of the EEGs, but you definitely need to know the types of seizures. And I'm going to go through some of the ways that they ask you and trick you, because it seems like a lot of you have not, you weren't given access to the essential notes, which has a lot more detail and understanding of material for your neuro exams. And it's kind of weird how the department wasn't giving you access to those. But we're going to go into a few of the seizures, just straight kind of definitions and the words associated with them. And so you have a few. You have clonic-tonic, and this doesn't have another name, but all it means for clonic just means that you have movement and then you have stiffness. So that's how this seizure is set up. You start off with movement. The person's moving all over the place, seizing, right? And then there's a stiffness, like a board. So movement, and then stiffness. And that's clonic-tonic. And then we have tonic-clonic. So that just is the opposite, where you're stiff first, and then there's movement. And there's also another name for this. This is known as your grand mal seizure. It's important to remember this name because that's usually how they ask them, even though they might not have taught you that. I know it's kind of annoying. Okay, next is going to be your absence seizure. And this one they really like asking because it's nice to set up a vignette this way. It's a little bit easier. They just say, oh, there's this kid kind of struggling in school. He's falling behind. They notice that he's walking through the park or something like that, and he pauses and he freezes in midair. He's staring into space. and then a few seconds later he just continues. And so this is an absent seizure. So if you were to poke that person during that time, they're almost like they're absent out of their body. It's really weird. And that's known as an absent seizure. And so it's kind of like a freezing moment. And it's usually in kids falling behind in school. Another name for these, this is actually going to be your other one. This is petite mal. It's going to be your petite mal seizure. And then last and most importantly, I know there are a few other ones, so definitely look at those definitions really fast, but these are the real high-yield ones. It's going to be your febrile seizures. If you want to memorize any of the EEGs, which you're not going to be asked to interpret them, but if you are, it's going to be this guy, so definitely know what this one looks like on EEG. You can simply just Google it and go, and it makes sense. It's kind of like paraphasic, and so it'll be baby's just fine, and then a few seconds they'll seize and they'll spread out their hands, and then they'll just be fine, and then a few seconds later they'll spread out their hands again. And so that's a febrile seizure, and you're going to see those in babies.
And so those are your seizures. You can study all the other ones, sure. Definitely understand like the tonic-clonic versus clonic-tonic and tonic-clonic-tonic. So those are kind of important as well, just what those words mean. They're going to describe a patient. They're going through this type of seizure. What is it? And it's particular just naming like that. All right, so now we're on to a little bit about the sensory pathways and a little bit about sensory information. So high yield for sensory is definitely fiber types, the receptors that you're going to find, especially for like proprioception and touch, pain, temperature, and stuff like that. Definitely know your Merkels and your Meissners and stuff like that. Just remember M&Ms are small. And so those are going to be your small receptors and small fields of reception. And definitely know their associated fibers. So when you're talking about vibration, touch, vibration, and proprioception, you're talking about these guys right here. You have to know the speed that they travel, and you definitely need to associate the type of fibers, both the A alpha and 1, both of those names for it, knowing that these are myelinated, which is what these reds represent, that these are large and medium-sized myelinated fibers, that they travel very fast, and that their names are here. Now delta, I'm not exactly sure. Definitely you might have to look at your textbook to figure out what that guy is, but it's a small myelinated fiber. It might be some of the pain fibers or thermal fibers, but most of your pain fibers are going to be going and traveling through type 4 or C fibers. And why they're slower, they're a lot slower, is why when you stab yourself, you're going to feel that initial touch first because it's traveling via these guys. But then you're going to have that secondary pain where it's like, ow! Or if you touch something hot, you feel the time when you touch that thing, but it takes just a few seconds before it's hot. Or if you're getting in your bath or something like that, and you have it really hot, you put your foot in, and you're like, oh, that's not too bad, but then like 2 or 3 seconds later, it's really hot. That is because of these C fibers traveling really slow. So that's definitely important to know that classification as they can pull out minor details like that. So let's do very quickly some of the pathways. I have these guys here, but we're not going to go into those right this second. We're going to talk about the dorsal column medium lemniscus. I'm sure by now you're experts and professionals at this. I'm going to do this very quickly. Definitely know where your arm or upper limb and know where your leg and lower limb are in all of these cross sections. I know it's not drawn here, but know them. You have to go in your atlas, in particular draw in each of the different color spots on where these are located. That's actually pretty high yield because they might show damage here as opposed to damage here. And that's something where you need to figure out, oh, that's their upper limb, or oh, that's their lower limb. So the dorsal column medium meniscus does your touch, vibration, and proprioception. And definitely understand that this person's fibers come in to the spinal cord. They're going to travel up and do a little bit of synapsing here in the medulla. So up through the spinal cord, stay ipsilaterally until they get to the medulla. They're going to synapse here and then travel and decussate across at that point. Then go up. Definitely know your contra and ipsilateral lesions and what you're going to see as far as the patient's symptoms. And then be able to take it from the patient's symptoms and know where the lesion is. You need to practice both. They're very important. Thalamus, you're going to lose a lot of things if you have damage here. And then definitely you have to know your homunculus. Definitely know your homunculus. Easiest way to remember this is imagine one of those sit-up, raised sit-up like table things. You know, they're kind of cushioned. You can put your legs up here and have your feet dangle down over the edge. So this actually looks kind of like a foot. And so you have your feet over here, you got your knees up here, and then you have kind of the whole rest of your body. And over here, your head kind of dangles at the very end of this kind of table, if you draw like a line right here. And it really exemplifies how your homunculus is. And if you can grab around your neck as you're doing this sit-up, that's going to emphasize where your hands lie as well. So you have your feet, and then your legs, and then maybe your thighs, and lower limbs, and hips. And then this is going to be your torso as it's progressing up to your hands and neck, and then this is going to be your face. Remember that the top of your face is actually here, and the bottom, or your lips, or your chin, is going to be actually located furthest laterally and inferiorly. So definitely know where your homunculus is, because they could actually show you just a neuroimaging picture and go, oh, what's most likely damaged here? And they just point to a spot. Or they can say, oh, this patient has loss of sensation in their lower limb, on their left side or something like that, and then have a bunch of these different labels all over here, A, B, C, D, E, F, G, H, I, J, K, and ask you where is the fiber sensory input for this in the cortex or something like that. So you need to know your homunculus and do an educated guess on where those are. Definitely know your cross sections as well. Those are high yield. You guys didn't do trigeminal. Now, however, now we have our pain fibers. So pain fibers, again, are traveling with your small myelinated or your C fibers, your A delta fibers or your C fibers. And this is important because there's some tricks in this, and this kind of comes down to as far as what you lose in Brown-Sicards and what you lose in syringomyelia. And so one of the major key concepts I want to get across to you is understanding where things cross, where things synapse, and what you're going to lose. Okay, so as far as the anterolateral system, this controls your pain and temperature. So pain and temperature are lost if you damage any along this anterolateral system. And where does this run? It usually runs in the anterolateral aspect of your spinal cord, the lateral aspect of your medulla, on top of your medial lemniscus, which is this kind of circular thing, and then on top of your medial lemniscus, which is this circular thing. This is retinaculus in the midbrain. And so that's where your anterolateral system is, kind of very lateral in your midbrain as well.
Okay, and so now we're here with Lasauer's tract, and this is very important when we're talking about the pain and temperature pathways. And how this is important in understanding what's going on is we want to figure out how or when we have lesions to the spinal cord that we're going to be able to have pain and temperature traveling or getting up to the brain so we can perceive that. It's pain and temperature are important defense mechanisms for the aspects of our safety, right? And so we need to first understand how those fibers come across. And you learn about the spinothalamic tract, which is your anterolateral system, where your pain fiber comes in here. and it comes straight across, and it synapses at that level that it comes in the dorsal column. Once it synapses there, we have a nerve that goes across the central commissure of your spinal cord, and then ascends through the anterolateral system, which is right up here, right in front of the anterior horn. And once that ascends up here, it's now contralateral to here. Once it crosses, it's contralateral to where you're having this pain and temperature coming in from. So say it's the right arm, and right hand, and I touch something hot, stove. It's going to come in through those fibers at this level, synapse dorsal horn, then cross over and ascend the anterolateral system, go up to the thalamus, synapse there, and then go on to my homunculus of my sensory system, your 3-1-2 Brodmanns. So that's your anterolateral system. But we also have an alternative track. So the main aspect and main point of our pain and temperature is to get from this side over here, to this side over here of your spinal cord. And how do we do that? I just told you about one way. Now let's talk about the second way. The second way is Lissauer's tract. Lissauer's tract allows your pain fibers to escape having to go across the spinal cord at the level that they're coming in on, but instead they can go up to, and they can also go down to. And so we have one spot here that can cross, and then we also have another spot down here. Let me see. You can see that. So we have another spot. So down to. So this is our Lissauer's tract, and this is important because we have two types of lesions that we're going to be talking about today. One is syringomyelia, and that is just kind of a swelling of the central canal, usually due to maybe an obstruction of the cerebral spinal fluid and increased pressure and enlargement of your central canal, and that impinges on this crossing in the central aspect. Then we also have the aspects of Brown-Sicard syndrome. So we're going to be discussing both of those today, but we need to first understand the basics of Lissauer's. So Lissauer's can come in and it ascends ipsilaterally to where it comes in from, 1 and 2, synapses in either one of these dorsal horns, also down 1 and 2, synapses in those dorsal horns, and then they all cross over to this main highway here. And once this crosses over, they can all ascend up towards the thalamus. All we need to do is get over on this side. And that is your Lissauer's tract. So now, how does this apply as far as these conditions? And I'm going to give you some tips and tricks and an analogy so that you can understand each of these syndromes. So let's go ahead and talk about, firstly, syringomyelia. So syringomyelia, again, I'm going to emphasize this point, is a swelling of the central canal, which is this purple right here. It's purple. And this kind of impedes inability for our pain and temperature fibers to cross at the central commissure. It does not impinge upon any of the dorsal column medium lemniscus system, and so your touch and proprioception is entirely fine in this condition. If this progresses, it progresses towards the motor cortex, and that could be damaged. So when you get to your motor systems, remember that this is a possible leading to damage for your motor systems. So just remember that as well. So you're going to lose pain and temperature and possibly motor if it swells far enough. You won't lose any of your temperature, your proprioception, and your touch. So let's talk about syringomyelia. So how they ask you questions is in two ways. First, they either give you where the lesion is first, and you have to determine where the patient's deficit is going to be. Where are they not going to, what dermatomes will they not feel pain and temperature? Or they can give it to you where they give you where this patient can't feel pain and temperature, which is the most likely case, and they're going to ask you where is the lesion. This is the classic neuro department question, where is the lesion? And so we're going to focus a little bit more on this one, but let's go ahead and give you some tips and tricks. for analyzing this. So let me do the analogy, and then I'll give you a straight shorthand for each of these two. Let me erase this Lasauer's tract. So can you just pretend right now you have you right here. This is you. And this is the top of your head, okay? And you're walking up to your friend. You see your friend, and you see that they've gained quite a bit of weight. They're a little bit round. And so here's the little head, and here's their body. And you want to give them a hug. So when we give you the lesion first, and we want to determine where you are, this is kind of the analogy how we analyze this. And so for when we give you the lesion first, this is what we're talking about. We're saying that this syringo, right here, your friend is the syringo. When the syringo is in place, it has a certain height and a certain depth. And so the height is going to be, say, C5. Maybe that's where they say this is the highest part of the syringe, and the lowest part is maybe T4. And so what you do, simply for this, is if they give you the syringe first, always remember that because of Lasauer's tract, we're really dealing with Lasauer's tract here when you're talking about this syndrome, only goes up and it only goes down 2. Up 2, down 2. So in order to determine how wide your reach can be, you just simply go like this. C5, C6, C7. So you go downward from the top, and you go upward from the bottom. So T3, T2. So here we are right here, C7 to T2, and that is how far your reach goes. C7. These are your hands, by the way. I know they're terrible. Let me redraw this part so you can. So here are my hands. They only reach out to C7. I'm going to label them hands so you don't get confused. So those are my hands. And they only reach out to C7 and T2. And you represent the loss. So this is the dermatomes. So the syringe is the large lesion, and you are representative of the loss in dermatomes. So your dermatome, where this patient will not feel pain or temperature, is going to be C7 to T2. So that's how you analyze when they give you the syringe first. And now if you want to analyze how to do it when they give you the pain and temperature, it's just the opposite. And this one's quite a bit easier. So this is where we have you again. It's the top of your head. And you want to reach out and give your friend a hug. But you see that they've been eating a little bit too much of some candy or something, that they've gained a bit of weight. And so this is what we're questioning. How big is this damage? How far is it? How tall is it? How low is it? So say we say this person can't feel from T1 to S3. So T1 to S3 is this range here. And we want to know how far up or down do you have to reach to grab your friend and say, hello, nice to see you. And so what you do is you go -2, or you just go down 2, and you go up 2. Up 2 from the top. So T1, what's above T1? C8. And what's above C8? C7. So the height of this, as far up, is C7. And we have S3 here. So we go, okay, this syringe is very huge. First off, this person's not feeling pain and temperature like throughout their entire spinal cord, but S3 we just go down to. So what's below S3? S4. And what's below S4 is S5. And so this is how big your friend is. And so that is how big that is. So let's do a recap very quickly. If they give you the lesion first, lesion first. That means syringe, syringo. You take the top and go down. Two, take bottom and go, I keep writing W, go up. 2, and those equal the top and bottom of where you will have deficits. In dermatomes. And then you have lastly location of pain and temperature. So this is where you have pain and temperature loss, and you just take the top and go up. 2 equals the top, and then you take the bottom and go down. 2, and that equals your bottom, and that equals where your lesion is, syringo is.
So dorsal column is totally intact, and these tracts are totally intact. It's just the crossing that is not intact. Lissauer's is the one that allows you to do this. Remember that you have this synapse, and know that Lissauer's is at the tip of your dorsal column, because they could simply say, oh, where's the lesion, and show you cross section. They have like A, B, C, D, E, F, G, and H is labeled right here. Make sure that you know that that is describing this pain kind of skipping.
Alright, and last but not least is going to be your Brown-Sicard syndrome. So what Brown-Sicard syndrome is we have our nice spinal cord, and we have a lesion that takes out half of it. We lose that. And so obviously, as far as right now, you're worried about your touch, vibration, proprioception, and pain and temperature, and where you're going to have deficits in. Once you get further, you're going to go over this syndrome, you're going to learn where the motor deficits are as well. But we're just going to cover the sensory. And so simply put, you have a little spinal cord. Let me draw this really fast. Oh, that is a terrible spinal cord. If I have a lesion that takes out this whole thing, then every fiber from this level, say it's C5, every fiber, pain, vibration, vibration, touch, and proprioception, which are your general sensory, is lost. Right? Everything at this level. So C5 is lost. C5 lost. You also will lose the pain input on this side. Why? Because you can't do pain at that level. You lose the entire spinal cord of that. Lose pain at level. Remember that one. That's a little trick. And then lastly, remember Lissauer's tract? It allowed us to take this one below it, skip up, go here, and if it synapses and cross, oh shoot, we can't go there, it's damaged. But this was only one. Remember, this can go up too, and so we can synapse here, and then it can cross above, and then travel up, and we have pain. Pain. So the loss deficit is when you get 2 below. Right? Because then we have Lissauer's tract that once it goes up to here, tries to cross, and it gets hit by all these dead cells. And this can no longer travel pain up. What about all the ones that go down? If it goes across, if we have our pain fibers that come in, they come in, synapse here, cross over, and then try to travel up your ALS, guess what? Once they get to this section, all these cells are dead. So you can't go through here. So you're going to lose all of pain contralaterally to where the lesion is to below. So if we're at C5, that's going to be C7 and below contralaterally. Loss of pain and temperature. Pain and temperature. That's contralaterally. Ipsilaterally, we will lose pain at the level, but nowhere else. Why? Because the C5 fiber comes in, but it has nowhere to synapse on, and it can't travel up Lasauers because this tissue, this whole tract is damaged. So you lose C5 at that level, but all these other ones are able to cross over and ascend on this normal side of the spinal cord, either below or any of the ones coming from C4 or 3 or whatever. Anything can get across. As long as it gets over to the other side, it can go. But this is just a nice major roadblock. You have to take a detour, and you can't if you're coming in from fibers from that level for pain and temperature. Vibration and proprioception, you're going to lose because this comes in at this level and gets hindered and blocked. And so you're going to lose at the level and everything below. At the level, and below, loss of PVT, proprioception, vibration, and touch. And that is pretty much Brown Sicards.
So hopefully that helps understand all these kind of neuro-annoying concepts. And definitely check out our other videos. Don't forget to subscribe. For any files I'll be posting, check out our Facebook. All right, thank you.